Our next speaker is Frederic Lamoth from the CHUV group in Lausanne. He's going to tell us about one of the cryptic species, Aspergillus calidoustus, something about the epidemiology and outcome, as I think it's one of the multi-drug resistant Aspergillus species. Thank you.
Thank you for the introduction. So I have about 20 minutes to talk about this very rare and marginal pathogen, which is Aspergillus calidoustus. So did you ever experience this Aspergillus group ustus infections in your clinical practice? Did you have in memory some particular case or history, or patient history with this? Who in the assembly had experienced this? Well, not that much. I will try to attract your attention about this pathogen. So these are my disclosures. So if you look at the epidemiology of invasive aspergillosis, we had the nice talks just before by Nina Khanna, but on the microbiology side, it's relatively simple. We have over 300 Aspergillus species, but we have actually one main pathogen, Aspergillus fumigatus, and three outsiders, Flavus, Niger, Terraeus. And this one accounts for over 90% of the invasive aspergillosis cases. About 1 decade ago, we started to use massively posaconazole prophylaxis, and it was shown to reduce drastically the incidence of invasive fungal infections, including invasive aspergillosis. But still, we have some breakthrough invasive infection. It's rare, but it still occurs. And what about this infection? Did the epidemiology change? Do we observe some change in the epidemiology? So this was a question that we tried to address in this study that we performed at Duke University. We took 24 microbiologically documented invasive mold infections, and this occurred under voriconazole or posaconazole prophylaxis, so mould-active azoles. And we compare these cases to the non-breakthrough microbiologically documented invasive infections. And as you can see, the non-breakthrough, these are mainly Aspergillus species in gray, and fumigatus is the predominant one. But now if you look at the breakthrough, you see that the color shapes are the biggest proportions, so there is a shift towards the non-Aspergillus molds. But you see that within the Aspergillus, there is also a shift in the microbiology. Now the predominant pathogen is this Aspergillus group ustus, accounting for quasi half of the cases. So I will tell you a clinical story that we experienced in Switzerland in my institution. It's very representative, very illustrative of this kind of infections. This was a patient with a very long history of hematologic cancer. She had allogeneic hematopoietic stem cell transplantation for acute myeloid leukemia, then recurrent of the AML treated with different chemotherapies, and finally we ended with remission. But she developed a severe graft versus host disease requiring intensification of the immunosuppressive regimen. For this purpose, she received antifungal prophylaxis with posaconazole, which was pretty good in terms of serum trough concentration, always above 0.5. But this patient was followed at the outpatient clinic, and we observed a progressive increase of the serum galactomannan. The patient was well. She had no complaints, no fever, nothing, but the galactomannan was positive. So you may say, why did you test the galactomannan? Because with posaconazole, there is no clear indication to test unless clinically indicated. So the hematologist thought, well, maybe it's a false positive. He continued to follow the patient. The galactomannan was persistently positive, so he finally decided to make a CT scan. Chest normal, brain, everything normal. 3 months later, the patient came back. And he asked, well, how are you, madam? She said, okay, I'm fine. No fever, no, okay. And then she said, oh, just wait. I need to show you something. She had 4 nodules, subcutaneous nodules, no pain in the shoulder and back. The galactomannan at this time was 6.4 in serum. The hematologist did the biopsy, first looking for a kind of recurrent leukemia in the skin, that he found these mycelial elements, clearly like Aspergillus septate, branched, and the culture grow Aspergillus of group Ustus. So this is the isolate that we recovered in this patient. You see the typical aspects. The face is grayish. The reverse is usually yellow, depending on the medium, but you can see sometimes an exudate, a pigment in the medium. Under the microscope, you have these typical aspects with the conidial head short and columnar. The phyalides are biseriate, and the conidia are typically rough, acuminate. In the section Usti, you have Aspergillus ustus sensu stricto and about 20 cryptic species. But it's important to mention that only 3 species in section Usti are able to grow at human body temperature, 27 degrees. These are Aspergillus calidoustus, pseudodeflectus, and granulosus. Aspergillus ustus sensu stricto cannot grow at 37. The other species, you need to go down to 30 degrees. All these species share the same particularity. They exhibit a kind of pronazole resistance. MIC to the 3 azoles are substantially higher compared to other Aspergillus species. Based on these experiences, we wanted to know a little bit more about this invasive Aspergillosis infection due to Aspergillus of section Usti. And we did this multi-center retrospective study in Europe. These are all the contributors. First author is Emmanuel Glampedakis. He's just here. And the paper has been just accepted in Clinical Infectious Disease. This was a study supported by the Fungal Infection Network of Switzerland, Funginus. We proceed. We did 2 manners to collect cases. First, we did a proactive case collection. We asked to all our collaborators to screen their microbiology database for any Aspergillus of group Ustus, section Usti, isolated from any clinical specimen. And for each case, they had to fulfill a clinical report form. If the isolate was available, they were asked to send us the isolates in Lausanne to the reference lab. In total, 8 European countries took part with 22 hospitals, a majority of French and Swiss hospitals, and we collected 90 CRF and 59 isolates. After analysis, 27 of the cases were classified as proven or probable invasive aspergillosis according to RTC-MSG criteria. The other were colonization. Then we performed a literature review of all cases of Aspergillus ustus published in the literature. And we identified a total of 45 proven probable cases. And you see, of course, there is some difference. The case from the literature, we have a significantly higher proportion of proven cases because obviously these are extraordinary particular cases that have been published. But we ended with a total of 72 cases. So which patients were affected? These were mainly non-neutropaenic patients, mainly patients who were transplant recipients, hematopoietic stem cell or solid organ transplant recipients, and receiving long-term immunosuppressive therapies, mainly anti-calcineurin drugs and corticosteroids. Example of the case, a clinical story that I have presented. About half of these patients were receiving mould-active prophylaxis, mould-active azole prophylaxis, in particular with posaconazole in 2/3 of cases. Most of the infections, a high proportion of the infections were disseminated. It means more than one organ affected in 1/3 of cases. And you see that the lung was affected in 76% of cases. So what does it mean? That in 1/4 of cases, you had only extrapulmonary aspergillosis. And you see that the skin and soft tissue were particularly affected, with 1/3 of cases presenting with primary or secondary skin or soft tissue lesions. We also see a high proportion of cerebral aspergillosis, about 14%. Galactomannan was positive in a high proportion of the patients that were tested in serum, probably reflecting the high rate of dissemination of the disease. If we look at the microbiology, for all the cases for which we received the isolates, we performed species identification by partial sequencing of the beta-tubulin and calmodulin genes. And we could collect this for about 80% of the isolates of the proactive caseary collection. Most of the cases were Aspergillus calidoustus, and you see that the remaining cases that were observed in this series or in the literature were extremely marginal, mainly due to Aspergillus pseudodeflectus or granulosus, not surprising because, as I said, these are the only 3 species able to grow at 37. Nonetheless, we observed a case of Aspergillus sensu stricto infection in a patient presenting only with skin and soft tissue infection. We performed antifungal susceptibility testing for 55 isolates, mainly Aspergillus calidoustus, but also other isolates that were recovered from colonization cases like Insuetus, Cavei, or Puneseus. And we saw that amphotericin B was the most active drug in vitro, with MIC comparable to the other Aspergillus species. You see that the azoles had poor activity, but interestingly, the level of activity of the different azoles in vitro was different. We see that isavuconazole was the most active in vitro compared to voriconazole, and posaconazole was really poor. Antifungal therapy was complicated. In most of these cases, the physician used multiple antifungals, either used combinations or consecutively. We tried to define a main antifungal therapy as the first-line drug that was administered for at least 7 days. And you see that in 39% of patients, the main antifungal therapy was amphotericin B, not surprising. But still in 36% of cases, the first line was defined as voriconazole. You see that combination therapy were used in many cases, either with an echinocandin or in some cases combining both amphotericin B and voriconazole. We tried to compare the patients who received amphotericin B and voriconazole. Amphotericin B were mainly formulation, lipidic formulation, and rarely deoxycholate, I need to precise. And you see that clearly the patient treated by amphotericin B were more severely healed, mainly hematopoietic stem cell transplant recipients with proven and disseminated invasive infections compared to patients treated by voriconazole who were non-hematopoietic stem cell transplant patients with probable and localized invasive fungal infections. The global outcome, we could monitor these patients, we followed mortality until 24 weeks, and the overall mortality was 58%. We consider that invasive aspergillosis was a probable contributor in most of these cases. This means that the disease was considered as a failure, stable, or progression at the time of death according to RTC criteria. If we look now at the factors associated with mortality, not surprisingly, the patients more severely ill at the basis condition, patients with hematopoietic stem cell transplant patients had higher mortality compared to the others, patients with proven invasive infections had higher mortality compared to probable, and patients treated by amphotericin B therapy had higher mortality compared to those treated by mainly voriconazole, which is not surprising because these were mainly the HSCT patients with proven higher treated by amphotericin B. So remains the question how we should treat these cases. And we did another study with a selection of 6 Aspergillus calidoustus strains of this study. And we looked for the in vitro activity of the drugs alone or combined, and also in an in vitro and an invertebrate model of infections using the Galleria meionella, the Vaxmox, the larvae of the Galleria meionella. And you see that in vitro amphotericin B is much better than voriconazole. But if we look in the Galleria model, both drugs were effective in treating invasive aspergillosis. It means that there is a significant effect compared to untreated, and the effect was similar. There was no superiority of amphotericin B over voriconazole. The combination with the classical drugs were not good. You see amphotericin B voriconazole in vitro was indifferent or even antagonistic in some cases. We did not test this in the Galleria model. And addition of caspofungin did not have any benefit. However, we found a positive interaction between voriconazole and terbinafine. The FIC was 0.5, so synergistic, but not very high level of synergism. But this was also significant in the Galleria model. The combination performed better compared to the monotherapies. It's interesting because terbinafine, as you know, is a drug mainly used to treat dermatomycosis of the skin. The drug has a very high accumulation distribution in the skin. And it's interesting because, as we have seen, Aspergillus ustus infections affect skin in a very high proportion of cases. If you look at the clinical data, we cannot really conclude because we had experience with both amphotericin B voriconazole, but many combinations, many bias, mainly due to the imbalance of underlying disease and case severity according to the first-time treatment with amphotericin B or voriconazole. So difficult to conclude. So what I would personally recommend on how I would treat these cases, I would still use amphotericin B for the more severe cases because this is the drug for which we have the best experience and the higher activity in vitro. For all the severe cases or all the azole breakthrough cases. But I think that voriconazole still remains an option that you can consider in selected cases with or without addition of terbinafine. This might be an alternative, for example, for the less severe cases. We have only probable invasive infections localized in less severely ill patients, non-hematologic cancer patients, or of course in patients where you need to stop amphotericin B because of nephrotoxicity and you have no other alternative, or a second line or maintenance therapy once you need to switch from an intravenous to an oral formulations for the maintenance treatment. Now the big question is the place for isavuconazole because we have no experience of treatment of these infections with isavuconazole, which was the most active drug, the most azole active drug in vitro. So in conclusions, I would say think about this Aspergillus calidoustus in non-neutropaenic transplant patients, in patients receiving posaconazole prophylaxis. If you have a persistently positive serum galactomannan despite absence of evidence of pulmonary invasive aspergillosis, this may be highly suspect. Or if you have any skin or soft tissue lesions in a patient at risk. Now the optimal antifungal therapy still remains to be defined, as I have mentioned. There are several options, but keep in mind amphotericin B is the most active, but maybe not the unique alternative. You may also consider voriconazole plus minus terbinafine. Thank you for your attention.